Hello, everyone, and welcome. My name's Samantha, and we're going to get started today. I'm a research coordinator at Moffitt Cancer Center, working with Doctors Guede and Mead in colorectal cancer prevention research, really centered in community-based participatory research and health literacy. So I'm really excited to be here with you all today. We're going to do one presenter at a time and then a short Q&A after each presenter and then more if we have time. So please feel free to go ahead and submit your questions in the Q&A portion. And our first presenter will be Annie. Annie is a study coordinator at the Huntsman Cancer Institute. If you want to go ahead and share your screen, Annie.
Yes, I will go ahead and do that. Okay, and I will get started. So my name is Annie Daly, and I will be discussing the conceptualization and measurement of genetic literacy by myself and Dr. Kim Caffings from Huntsman Cancer Institute at the University of Utah. Okay. Our reason for doing this research is that genetic communication is becoming increasingly important, and a necessary component of this is genetic literacy. Genetic literacy is critical for communication, comprehension, and decision-making. However, there is still inconsistency in how it's being measured and defined. So these variations and conceptualizations lead to different research focuses and findings, and may also create inconsistencies in the development of conceptual frameworks of the associations between genetic literacy and different outcomes. So our objectives for this study were to determine how genetic literacy is being defined and measured, the similarities between definition and measurement, and the concordance between commonly used measures. We started with a systematic review using 8 databases with the search term genetic literacy or genomic literacy, and we included papers that were in English language that presented original data and used a quantitative measure of genetic literacy. We found 92 articles total, from which we found 110 uses of genetic literacy measures, and we extracted information on study characteristics, definitions, and measure properties and content. And then we did descriptive analyses and also thematic analyses for the definitions. And then after completing our review, we also administered an online survey on Qualtrics that contained 6 genetic literacy measures that we had identified as being used 3 or more times during our review, which are listed on the side there, as well as a health literacy screener, subjective numeracy scale, and demographic items. And then we performed descriptive analyses of demographics and Pearson correlation to determine the relationship between measures. So from our review, we found that 40% of measures were assessed for reliability, with the most frequent type by far being Cronbach's alpha at 82%, followed by test-retest at 10% and Pearson correlation Spearman-Brown and item total at 3% or less. And similarly, about 40% were assessed for validity. However, of these, only 57% provided the information on how they were validated. And of those, about half were content or phase validity, 17% concurrent, 13% construct, and 10% predictive, with criterion and discriminant occurring about at 3% each. And then we also found that 41% of measures were adapted, most commonly just creating a new measure using items from one or more existing measures, or just using an existing measure but omitting items. So moving on to definitions, only 38% of papers actually defined the concept that they were measuring. And the most frequent definition used, which was about 7 times, was from Bowling 2008, who defined genetic literacy as sufficient knowledge and appreciation of genetic principles to allow informed decision-making for personal well-being and effective participation in social decisions on genetic issues. When we looked at the cognitive domains in genetic literacy definition, we found that they contained 1 to 4 different domains, averaging 2.21, standard deviation 0.84, and 31% of definitions included objective conceptual knowledge as a domain of genetic literacy, while 28% included applied knowledge in a personal context, 20% include comprehension or understanding of genetic information, 15% include applied knowledge in societal context, and then applied knowledge in professional context and print skills were found in 5% or less. And so we also categorized the actual genetic literacy measures according to the cognitive domains that they were actually assessing, and we found that largely most of them were just measuring objective conceptual knowledge at 76%. 18% of measures also assessed self-rated or self-reported knowledge, and then 3% or less were assessing comprehension or applied knowledge in any other context. So looking more in depth at the actual content of the measures, 19 of the 110 were word recognition, in which participants indicated their familiarity with genetic terminology, and there were 258 terms or 124 unique, and a pretty wide range of 3 to 63 terms per measure, averaging 15.82. And the most common vocabulary that were in these measures were chromosome, mutation, gene, and DNA, and then less frequently seen were terms such as pharmacogenomics, targeted therapy, and personal genome DNA. And then we categorize measure items according to conceptual domains, excluding vocabulary lists. And we found that measures include a range of 1 to 18 concepts, averaging 4.74 and standard deviation 4.16. And the most frequent conceptual domains included items pertaining to genetic material, genetic mutations, autosomal disorders, and sexual reproduction and heredity. And less frequently found domains in the items were, for example, the actual definition of genetics or genomics, race and ancestry, and germline or somatic mutations. And here we have some examples of the items for a few different conceptual domains, which also demonstrates the variability within individual domains in terms of the difficulty of items. For example, in genetic mutations, which is the second row, we see that some measures assess whether the participant knows the fraction of genetic variants known to cause disease, while some are true and false questions about whether a person with an altered gene is healthy or not, and some simply just ask the participant to rate whether they have knowledge on genetic disorders. And we also looked at whether these items differed according to the population that they were designed for. So we looked at whether the measure was designed for medical professionals or just general population. And so you can see that the first 3 items in genetic mutations, they were all designed for non-medical populations, and then the final item was for medical professionals. So the differences in items remains even after accounting for possible population differences. So moving on to the results from our survey, we had 539 participants in the analysis. Most had more than a high school degree, average 35 years of age, identified as female, white, non-Hispanic, Latino, with either private or public health insurance, and no history of genetic testing. Looking at the correlations between measures, we found that most genetic literacy measures had weak to moderate correlations with each other. Subjective numeracy and health literacy also showed similar relationships with genetic literacy measures, and only the genetic literacy and comprehension measure, which is the GLAC, had a stronger relationship with the GLAI and Fitsko-Butz measure. So overall from our study, we found that there was a lack of a common definition of genetic literacy, and that genetic literacy measures are likely measuring different component domains. So just to break this down a bit more, most papers do not define genetic literacy, and amongst those that do, there was clear inconsistency in what cognitive domains actually make up genetic literacy. There was also incongruence between definitions and measurement, with most measures only assessing objective conceptual knowledge, despite definitions also mentioning comprehension and applied knowledge as components of genetic literacy. We also observed variation in the amount and types of content domains and measures when examining their items, and variation within the individual content domains themselves. Papers also did not often report psychometric properties of the measures, and there was a notable lack of concurrent and discriminant validity. In addition, measures were pretty frequently adapted, yet it was unclear whether these measures were reevaluated for psychometric properties after being adapted. And lastly, and most importantly, there were only small to moderate correlations between most measures. So our suggestions are to first come to an agreement on a consistent definition of genetic literacy. One proposed definition, which includes both objective knowledge, comprehension, and applied knowledge, is to think of genetic literacy as sufficient knowledge and understanding of genetic information to allow for effective communication and application of learned information and informed decision-making in personal, societal, and professional contexts. It's important to also develop standardized measures of genetic literacy that match definitions, and to also come to a consensus on the concept domains that are critical to being genetically literate, and to actually include this in the measures. And lastly, we suggest more extensive psychometric evaluation of measures, and to specifically include dimensions such as concurrent and discriminant validity. So I've listed all of my references as well as my email here, and I appreciate everyone listening and welcome any comments and questions. Thank you very much.
Thank you so much, Annie. Please feel free to put some questions in the Q&A box for Annie. I think this is a really interesting topic. I think that you really highlighted the inconsistencies and the current gap in the literature that you found. So I think that's really interesting. I have a question that we can kind of get started with as people are submitting some questions for us. So after, I guess, everyone can kind of agree on a good definition moving forward, what would you kind of say the next steps are? Is it trying to figure out how to increase genetic literacy? Any ideas on that topic at all? What are your thoughts?
Yeah, that's a good question and a big question. I think there's a lot of directions that you could go with it. I think after agreeing on a definition, it's important to then actually implement that into the research in terms of creating, as I said, the measures that match the definition, and I think implementing that into research that we can gain a clearer and more, I guess, a clearer sense of where we're at and what directions we need to go in. I think that's a good place to start.
Thank you. And we did have a question in the Q&A box. So they said, it's great that you recommended a common definition. How did you derive the elements that went into your definition?
Yeah, so we actually started looking at other areas of literacy in the literature. So we looked at health literacy, we looked at psychological literacy, and media literacy. And so we saw that a lot of these contain common components, which were objective, knowledge, and then applied knowledge in different contexts, and comprehension and understanding. And so we kind of integrated all of those into a definition for genetic literacy that might fit well into the overall literacy literature.
Thank you. And one more question here. Have you looked at current genetic textbook definitions?
That's a great question and a good suggestion. We did not look into actual textbooks, so that would be definitely an area to look more into. We were only looking at the online literature, research literature.
Sounds like your next study. There we go.
Thank you.
I don't see any other questions. Anything else you wanted to share, Annie?
No, just thanks so much for listening, and I appreciate the questions.
Oh, we did have one more just as we were about to close. Okay. Have you done any work in assessing how well patients going for genetic counseling actually understand what is being told to them? Perhaps you could capture those words, concepts that are confusing or most unfamiliar.
Yeah, definitely. I do think that there's some literature out there. Even I believe my supervisor, Dr. Kim Kapp, thinks she does a lot of work in this area. We recently even did a study kind of looking into, patients in genetic counseling. And it does seem like there's a bit of misunderstanding at times. And so I think it's definitely important for us to kind of understand what terms are not being well understood and how we can better improve educational intervention. So that's a whole other big area.
Sounds like it. Sounds like it. Well, thank you so much, Annie. And then please feel free to continue submitting any questions. If we have some time at the end, we can bring everybody back up. Okay, next up we have Michelle Sanders. Dr. Sanders is an assistant professor at the University of Rochester in the Department of Family Medicine. If you want to go ahead and start sharing your screen.
Can you guys see the slides?
Yes, we can.
Okay, great. Thank you all for being here today and allowing me to briefly share the results of my team's study entitled The Impact of Patient Coaching on a Teach-Back Intervention Around the ABCs on Patient-Provider Discussions. So first, some housekeeping. The work for this presentation is funded by 2 grants from the National Heart, Lung, and Blood Institute, and we have no conflicts of interest to report. So quickly, brief background. Thankfully, HIV is no longer a death sentence. And this is due largely to the HIV antiretroviral therapy that has been available, and it's reduced deaths from AIDS-related causes, which means people are living longer. And we see the same types of diseases that we see in the general population, especially cardiovascular disease. And to that point, there are ways that we can prevent cardiovascular disease, namely through the ABCs. The ABCs include taking aspirin when appropriate, blood pressure control, cholesterol management, and smoking cessation. And so the goal of our HIV ABC study was to reduce the cardiovascular disease burden among those with HIV through the ABCs in a group of safety net practices in the United States. But today we're going to focus on a sub-aim of the study, which was to assess the impact of patient coaching on discussions that they had with their providers about their ABCs options. The choice of an ABCs option should involve a shared discussion between a patient and their provider. However, as you know, there are barriers that can prevent them from being engaged in such a discussion. We have a few examples listed here, including provider communication skills, perceived power dynamics between the patient and the provider, language discordance, limited education and health literacy. And then for our study, we intervened on two of those factors. We intervened on limited health literacy and perceived power dynamics between the patient and the provider. We developed a coaching curriculum for peer coaches and research staff to address limited health literacy and the power dynamics. The coaches engage patients and teach back around the ABCs. So by definition, peer coaches often have a shared sociocultural position with the patients that they serve, which can help eliminate the power dynamics that you may see between the patient and the provider. And as you know, teach back is a simple yet effective communication method that's can be used to check for patient understanding, and it's been shown to be especially useful in patients with limited health literacy. And this diagram here outlines our approach. So briefly, the coach explained the ABCs to the patient, checked with the patient to determine if they explained the information correctly, clarified any gaps in understanding and communication when necessary. And then after the teach back was complete, the coach then encouraged the patient to have a more in-depth discussion about the ABCs options with their primary care provider during their next scheduled clinical visit. So how was the ABCs rolled out? The study took place in 3 geographic locations: New York City, New Jersey, here in Western New York, and then in Dallas, Texas. And there were 9 safety net practices that participated in the study, most of which were federally qualified health centers. The study was rolled out as a stepped wedge cluster randomized control trial, meaning that all of the sites received the intervention, or all of the patients received the intervention, but they were randomized as to when they would start. And so the first group, which we call Wedge 1, included 3 sites, and the subsequent sites started years 2 and 3. So the results. Here's a snapshot of the patient sample. We had 471 patients that participated in the study. Our sample was primarily male. Most patients identified as Black, and a quarter had less than a high school diploma. We assessed numeracy skills using Lipkis's 8-item survey. And we chose this because it didn't require respondents to make mathematical calculations. There's no correct or incorrect answers, and instead, respondents can assess their numerical ability in different contexts and then state their preferences for the presentation of the material or information. So here's an example of one of the items on the survey, for those of you that may not be familiar. When you hear a weather forecast, do you prefer predictions using percentages? For example, there will be a 20% chance of rain today, or predictions using only words. For example, there's a small chance of rain today. Respondents used a 6-point Likert scale on all response options, and then the overall score for the scale is based on the average across the 8 items, with scores that can range from 1 to 8. Our sample had a range of 1.3 to 6, which is slightly lower than was allowed on the scale. And the median score for our sample was 4. And this was, again, slightly lower than what was reported in the original validation of the scale, which had a median of 4.5. So here we have outcomes related to patients' understanding about what CVD risk was and the use of the ABCs. Recall that teach-back diagram that we had earlier. The peer coach asked the patients if they knew what CVD risk was, what the ABCs were, why they were important. And then patients that didn't know were given a plain language explanation by the coach and then asked to teach back what they learned to check how well the peer coach had explained the information. We recorded the results at 3 time points. So prior to the coaching, or what we call pre-baseline discussion, immediately following the baseline discussion, and then roughly 2 months later. So as you can see, before having this discussion, about 1/3 of the patients could state why the ABCs were important. After the coaching session, 62% could immediately teach back why they were important. And this finding held for at the next assessment, which was approximately 2 months later, where 61% could still teach back that information to the peer coach. Of interest, roughly half of the patients reported having a discussion with their provider about the ABCs at that 2-month follow-up session. So here we report the odds of having that discussion with the provider, given the patient could teach back what the ABCs were or why the ABCs were important. Interesting, the unadjusted odds of having a discussion were significantly higher among those that were able to teach back why the ABCs were important at follow-up, even after adjusting for potential confounders. So some lessons learned. So we have a few to share. First, teach back has traditionally been done in the literature by nurses and physicians. And to our knowledge, our study was among the initial to show that this type of intervention can be successfully delivered by members outside the clinical team. So therefore, peer coaching with teach back could be an effective and sustainable, cost-effective strategy to improve discussions around CVD prevention in patients with HIV and safety net practices. And second, the ability to teach back why the ABCs were important and not what the ABCs were was associated with self-reported patient-provider discussion. And this is important when we make decisions about what information is necessary for patients as in the clinical realm. It takes a village. This work would not be possible without the incredible members of the team, again, including members from University of Rochester, Parkland, and the Clinical Directors Network. Here is my contact information for those that are interested. And thank you for allowing me to share.
Thank you so much, Dr. Sanders. That was such a great presentation. I think my first initial kind of takeaway, while folks are submitting questions for Dr. Sanders, please put them in the Q&A box. I will get started with my question. I think that we make acronyms for everything, especially in the kind of healthcare space. So would you say that focusing more on the take-home messages rather than all these alphabet soup letter things that we assign to things might be really helpful for patients?
Absolutely. And as you can see, there was alphabet soup in my presentation. So we're exposing patients to CVD, which is like heart health. And so, you know, that piece, and then the ABCs, it was more as a way for them to remember what their 4 choices were. And so absolutely, I think focusing on the why and the big picture is key.
Yeah, I think you convinced me at least. I think that's really, really important. I think even for me personally, there are some times where I'm like, but wait, what is this? So that's really great. We did have a question come in the chat. Can you expand on your finding that why was more important than the what, which I think you just did a little bit, but anything else you want to add?
Yeah, so during the coaching session, the coaches really drilled home for the patients that the ABCs were important because it would help reduce their risk of developing heart disease in 10 years. And the what for the ABCs was, could they teach back what the ABCs were? So aspirin, blood pressure control, cholesterol management, smoking. So we found that them knowing what the ABCs were was not as important as knowing why it was important to engage in heart healthy behaviors.
Thank you. Our next question is, thank you for sharing your work. Were you able to determine whether the effect you saw on the about 62% of patients was influenced by the skill of the peer coach?
That's a great question. So right now we're going through the fidelity of the teach back. So we're looking at if the element occurred and then how well the peer coach delivered the given element. And so stay tuned, more to come on that.
We will definitely stay tuned. Okay, our next question is, did the peer coaches receive any training in health literacy before the study?
Yes, so we went through 3 weeks of training with 2 sessions per week for 90 minutes. And so we focused a lot on teach back, so the importance of health literacy, but the key was really the teach back skills, which is difficult for, I know I'm preaching to the choir, but yeah, that's kind of where we focused our energy.
Well, thank you so much. I don't have any other questions in the chat. We can hold for a couple more seconds, see if anybody has any last minute ones. If not, we can always circle back at the end if there's time. Well, thank you so much, Dr. Sanders. That was excellent.
Thank you.
Next up, we have Stacy. Stacy's a medical librarian and social media coordinator for medlineplus.gov. If you want to go ahead and start sharing your screen, and you can get started whenever you're ready. Oh, I think you're muted.
Can you hear me now?
Yes.
Okay, great. All right, let me get this put up here. Can you see my screen?
Not yet.
No? Okay. Bear with me for just a moment.
No worries, no worries.
All right, how about now?
Now we're good.
Okay, great. My name is Stacy Koppas. I'm from the National Library of Medicine, which is also part of the National Institutes of Health. And specifically, I work on Medline Plus. And just a side note, I am not one of the authors on this study. None of the authors were able to come to this presentation, so I am filling in. That being said, if there's any questions, I will answer to the best of my ability, but I might need to get back to people after corresponding with the authors. So today I'm going to talk about a study that we recently did for Medline Plus on the impact of visual aids on understandability of health education materials. And my objectives for this presentation is I hope that you think critically about how different aspects of photos can impact people's understanding of health information, apply best practices for using photos in health education materials designed for people with limited health literacy skills, and understand some of the current open questions about using visual aids in health education materials. Some background information. Medline Plus is an online health information resource for the public. It is a service of the National Library of Medicine. And we aim our content at a 6th to 8th grade reading level to reach the widest audience that we can, while also remaining accurate with our health information. We had some content on our website that was labeled easy to read, which is an even lower reading level, but this label was based on the author's content, the content that we've have from other institutes. So say the National Institute of Dental Care might say this link, this website, this content is easy to read, and we would use the label as such. We wanted to look at that further and assess whether this information was actually easy to read. We researched health literacy best practices in order to create a health education materials assessment tool, HEMAT. And then we wanted to refine it as well. So we wanted to assess the information that we had on Medline Plus to make sure that it was reaching the most people. And for the refinement, we wanted to make sure that people understood the numbers we were using, specifically things like health risk percentages. And then the part that I'm going to talk about is the inclusion of visual aids on whether that helps with readability. Our research questions starting out, we wanted to see to what extent do visual aids contribute to consumers' understanding of health education materials, especially the main message. I think if you would survey the people in this room, most people would say yes, images help people understand content. But what aspects of the visual aids help the most? And to what extent do culturally relevant visual aids contribute to consumers' understanding of health education materials, especially the main message? And then our second question, to what extent do visual aids impact perceptions of readability? In this study, we had 2 fact sheets, one on HIV medicines and how to take your medication properly, and on preventing lead poisoning in children. So each fact sheet had 4 versions. The first version was a photo representing the priority audience. So for HIV medicines, the priority audience was gay men, and for preventing lead poisoning in children were parents. So these are the 2 images that were found on the fact sheets for the priority audience. The second version was a photo supporting the main message. So it wasn't a priority audience, a picture of the priority audience, but something that also supported the main message. For HIV medicines, we have an image of a pillbox, and for preventing lead poisoning in children, we've got a windowsill with chipping lead paint. And then we also did a generic photo to increase visual appeal. No information really is going to be conveyed on this photo of a stethoscope other than that it's a fact sheet with medical information. But we are also testing whether just having an image at all could increase readability. And then for our control, our last version, it had no photo. We also explored captions and how they may impact understanding. So we drafted captions that supported the main message or were more generic. So for each fact sheet, some participants viewed 4 versions with the main message supporting caption, and some participants viewed 4 versions with a generic caption, and some participants viewed 4 versions with no caption. So 23 participants with low or moderate health literacy skills were part of one or both priority audience groups. We had 16 participants that were parents and 15 participants that were gay men. And in this study, via a Zoom chat, they were randomly assigned a version of the fact sheet on their own, and they took a look at it, reviewed it, and then the moderator asked them questions about their understandability of the fact sheet. Second, they were given all 4 versions of the fact sheets at the same time, and then answered questions from the moderator about readability, understandability, and cultural relevance. So our findings, not too surprising, participants said including photos and health materials make them seem easier to read. Nearly all participants chose versions with photos, and even some participants said photos helped with readability by improving the layout and breaking up the text of the material. So even that image of a stethoscope had some importance just because it was making the layout easier to read. Participants highlighted the importance of creating engaging materials, even when we didn't ask if materials were engaging or caught their attention. Participants noted that the importance of including a photo to draw them in, saying that they're less likely to even start reading a material with no photo, which is interesting. Also, they said the human element of photos made them more appealing. The most readable per their response was the photo of the people. The priority audience photos, because those photos were either relevant to them, they saw themselves in those photos, or because the people in the photos were happy and the photos seemed bright. Just as an aside, because I'm the social media coordinator at Medline Plus, we also see that in our social media channels, even if it's a topic that is not as happy as others. If you show a person who are a photo that is bright and happy, it generally does better for us than other photos. And moving on, the participants indicated that their culture, everyday life, and lived experiences greatly impacted whether they thought materials were relevant, relatable, and engaging. So again, they want to see themselves in the photos. They expressed a preference for photos that were relevant or relatable to them. For example, most of the gay participants indicated that they liked the photo of the gay couple. Some participants said relevant and relatable photos were most likely to catch their attention. They know that that health information is for them because they see themselves reflected in the images. For the captions, participants said that the captions didn't increase their understanding of the materials, and most didn't even notice the caption until the moderator pointed it out. Of course, captions can be used in many different ways, but if we're trying to convey information or increase readability for the general public, the captions didn't help in that. So recommendations based on this small study, visual aids like photos make health education materials easier to understand, more engaging, and more relatable. They should represent priority audiences. Again, people want to see faces, or at least support the main message. That was the images of the pillbox and the windowsill with the peeling paint were second in the popularity from the participants after seeing faces. And according to the findings, captions aren't necessary for the types of visual aids tested. Of course, this was a very small study, and we did it for the specifics of creating an assessment tool for health literacy. Future research could involve whether photos or illustrations or data visualizations increase understandability as well, and which ones. And if one image helps people understand health information, does multiple images increase understandability? I think that would fall mainly into the priority audience category. If you're trying to reach a broader audience of people, having relevant images of all of your demographics could help. And then when is a visual aid too distracting? How many or of what type that could actually hinder readability? So I flew through this, but that is my presentation.
Thank you so much. Please submit your questions for Stacy in the Q&A box if you're able to. And then, do we have a raised hand?
Yep. Hi.
Hi.
So there's so many different things that could be called a visual aid. Like a photograph of the target population, or like, that it just seems so different than many of the other things, So like curb appeal is different than like, say, medical images, right? So maybe this isn't really a question. I would just say that I've looked into this a bit, and there's an extraordinarily small amount of data actually about medical images and what people actually understand from them. And I would say this is likely, a fantastic landscape for great opportunity of research in health literacy. Maybe even a new dimension of health literacy would be, about medical images and that whole space. Even, this is different than, say, representing a chart data in a chart or something, like, which is another type of a plausible image but I don't know if you want to share comments about this. I know you're presenting this work for them, but
yeah,
I would say it would be fantastic if NLM would get involved with this topic.
Definitely. I do see where you're going with that. It depends on what your objective is in health literacy. Are you trying to teach someone a specific the way to use your insulin pen? Would, I think an illustration of that would be more helpful than just a happy smiling face. But then you also got to think about the engagement. What would encourage someone to pick something up to read or to click on something to read it? If you don't get the eyes on it to start with, then they're not going to learn. So definitely there's a lot of research that could be done with the visual aids.
Yeah, so there's yes, I agree with orienting towards the agenda. Like, so engagement is a good agenda, but you know, if part of the agenda is knowledge transmission or maybe empowerment or understandability or actionability, you know, so well, many health education materials include images, for example, of the body, and you know, magically being able to see inside of people's bodies or microscopic views of parts of their bodies. We have extraordinarily little understanding of what these things mean to people. Are they freaking people out? Are they socially appropriate? Maybe they're inappropriate in various senses or culturally inappropriate in various ways. Do they what do they communicate? Are they, you know? So I would say there's a massive amount of fantastic work to be done here. And it would be great if NLM would be basically a health literacy funder as well, you know, to promote this kind of work.
Great. I'll take that feedback back to the authors. As an aside in relation, I am the social media coordinator for Medline Plus, and we recently started an Instagram account, and we have found that animations of cringe-worthy procedures like root canal actually do the best on Instagram. People really enjoy seeing that kind of thing.
They're you called them cringeworthy, but then you said they really enjoyed them. So can you say more?
That's true.
What you mean?
Yeah. Well, they're popular. We get a lot of engagement, a lot of shares, a lot of eyes on them. Most people, I think, if seeing a video of a root canal might find it a little uncomfortable to watch. It's a phenomenon that people, you know, it's a train wreck. People don't want to look away. But I'm sorry, I don't mean to get off track, but
no,
just similarly, it's in the similar vein, whether, you know, anatomy videos or images are what people want or need.
Yeah, no, the moving images is the next is also part of this conversation. So I don't think that's at all irrelevant. You know, more and more we can do that too, more moving images, but that's just an additional vista for what do people understand. And yeah, people want your Instagram account name there. If you could put it in the chat. Yeah.
Oh, okay, sure.
Someone also shared that it's the Dr. Pimple Popper phenomenon.
Yes,
just this thing where you
I didn't want to say that,
enjoy.
but yes.
It's a good point. It's a good point. And then someone else shared in the chat as well. We received feedback in user testing that photo image used was too happy, too young and healthy looking on a recruitment flyer for a breast cancer study. Could you talk a little bit maybe about that kind of nuance?
That's an interesting point. I cannot.
That's okay.
Yeah. That's a good point. Yeah, there can be. I mean, when we're looking for stock images for our website, we're always trying to look for real people, and the most that we can find is the happy white skinny people. I'll be blunt there, and we've got to really dig for real people. So yeah, I think that's a fine line between advertising, making things look too shiny, too happy, and showing the real deal. Yeah, that's something I think that would need further study.
I think it has a lot just with my personal thoughts. I think it has a lot to do with what you were saying about the intent or the agenda that you're looking for. In that case, for example, it might not be as appropriate to show someone looking too happy, but also making sure that they do look like real people, like you're talking about. That way they're relatable.
Right, seeing themselves in the photographs. Yep.
Okay, so we have a couple of questions as well. First one says, were there any other choices other than the image of a windowsill to convey lead poisoning? So any thoughts on the images available?
Well, so no other photos were used in the study. As a broad idea, there definitely could have been other things that we could have used. I think the lead paint is usually in old houses the main culprit, as far as I know. But I'm sure there were other photos that could be used. I know one participant had said that they liked the window photo because it helped them visualize what they should be looking for in their own house. But they definitely could have gone in different directions.
Thank you. Okay, our next question, it says you mentioned that photos enhance the content from a structural perspective. What are your thoughts about placement of the photo? Would the impact if the photo is at the beginning, middle, end?
Yeah, that's another good idea. I don't know offhand. I know that they did talk about drawing people in, and I would assume that photos at the top might draw people in, but I don't know offhand. Another that sounds like another good study.
I think so too. I think so too. I think this is where also your kind of social media background is really interesting because you want to kind of engage people and then keep them engaged to keep reading.
Right.
One of the questions that I had, I found the caption not really increasing understanding finding to be interesting. How does that kind of shape your perspective as a social media coordinator?
Well, when we add captions to photos on social media, it's for other reasons. It's for, 508 compliance. So we know that in social media, the alt text is embedded within the photo, so you wouldn't see it unless you open it up and click it or you have a screen reader. So it's not noticeable to anyone else. Yeah, I did find it a little strange that that was something that came up out of the results of this study. I think captions are important for lots of reasons, not just for the general public or understandability. So I think for the most part, they're necessary. Yeah.
Thank you. Yeah. Just a couple comments in the chat as well. Within our outreach, we try to pick photos that represent our community members. Many times Shutterstock, Getty Images can also look modelly too, which is I think what you were sharing
Yes.
that you found as well. Yeah.
Yeah, we definitely have to dig. We use Shutterstock. We'd have to dig and be creative with our keywords to find the photos that we want.
And then someone else commented, with phone cameras as great as they are these days, I'm curious why more organizations aren't taking their own photos.
I would think time. The time that it takes to create messaging, taking the time to actually create photos as well, I think would be too much unless you had a large staff, which most government agencies do not.
Definitely an idea though.
It is, yeah.
Next one, a caption on a generic lifestyle photo really wouldn't provide any useful context. We use Getty, but also can take a lot of our own and use medical illustration. So maybe the mix of both. And photo editing skills, someone shared too. Yeah, sometimes you need good photo editing skills.
Sure.
Our next question, in addition to engagement, were you able to determine if one type of image increased comprehension of the take-home message?
Yeah, so the images of the priority audience of people came up as the most readable, most engaging overall. again, seeing themselves reflected in the images. So they knew that's who the fact sheet was supposed to be. They were in the intended audience.
Gotcha, perfect. And then someone else shared, actually, photo editing is really easy to figure out on an iPhone. So just sharing some resources in the chat. We always appreciate that. Okay. Did anyone else have any questions for Stacy? I think we had a really great discussion. Any further ideas about how to tailor our health communication, Stacy, that you didn't already share?
I don't think so.
Okay, perfect. Well, thank you so much for filling in. I thought you were just excellent.
Oh, thank you.
Next up on our presenter list is Jenny. Oh, there we go. Hi, Jenny. Jenny's an instructor of medicine and preventive medicine at Northwestern University, Feinberg School of Medicine. And if you want to go ahead and share your screen, Jenny, you can get started whenever you're ready.
Sure. All right, does that look good?
Looks good
Sorry.
to us. Oh,
Sorry.
it was there for a second. Okay.
Is this in the presenter mode or in the
Yes.
like
Yeah.
in the full screen mode?
Full screen.
Okay, wonderful. Thank you so much. It looks a little bit different on my end. Okay, well, thank you so much for attending my talk. It's on the influence of health literacy and numeracy on a behavioral workplace intervention. My name is Jenny Jha, and we have no disclosures. So health literacy and numeracy affect comprehension of health information, diagnostic tests, disease management, and risk communication, which have implications on adverse health outcomes and health behaviors. Numeracy is ability to understand and use numbers in daily life. And health literacy and numeracy are moderately correlated at the individual level. Particularly, individuals can have adequate health literacy, but poor numeracy. And it makes these both important dimensions to look at for differential effects of behavioral interventions. So our study is a secondary analysis of the Choose Well 365 RCT, which enrolled 602 hospital employees from Massachusetts General Hospital in order to test an automated tailored behavioral intervention that leveraged cafeteria purchasing data from the employees, as well as pre-existing traffic light nutritional labeling in hospital cafeterias, meaning foods in the hospital cafeterias are labeled green, yellow, or red, green being healthiest, red being least healthy. Over 12 months, intervention participants received emails with personalized calorie information, tips about health and food choices, and letters with personalized peer comparisons and financial incentives. All of this based on the health profile of each individual's recent cafeteria purchases. The control group received a general letter each month. The key findings from the parent study were that there were no differences in BMI or diet quality between intervention and controls, but they did find that the Choose Well 365 intervention participants purchased more healthy foods in the cafeterias at 12 months, and these changes were sustained 1 year after the intervention ended compared to the baseline purchasing. So we received funding to do ancillary studies during the main trial. And one of the studies was looking at health literacy and numeracy as moderators of the Choose Well 365 intervention. We hypothesized that Choose Well 365 would have a greater benefit on diet quality and weight gain in those with lower numeracy and health literacy. The study collected measures of health literacy and numeracy at 12 and 24 months. We measured health literacy using the newest vital sign, which many people I'm sure are familiar with, but it's a series of 6 questions focused on interpreting an ice cream nutrition label that tests health literacy, and actually even some basic numeracy as well. It's not surprising that in our sample of hospital-based employees, the newest vital sign scores were generally high, with a median score of 6. Newest vital sign ranges from 0 to 6. So in order to categorize people, we dichotomize health literacy to lower or less than the sample median versus higher or greater than, higher meaning greater than or equal to the sample median. So lower health literacy ended up being newest vital sign score 0 to 5, and higher was newest vital sign score of 6. For numeracy, we use a 3-item general numeracy scale, which focuses on percentages and proportions, and the range is from 0 to 3. Looking at the distribution of the scores in our sample, they were pretty evenly distributed between 1 and 3 questions answered correctly. So the median score ended up being 2. And we again dichotomized according to the median, with lower numeracy being general numeracy scale scores of 0 to 1, and higher being GNS 2 to 3. For our outcomes, they were collected at baseline, 12 months, and 24 months, and they included BMI, diet quality, and cafeteria purchases. All of them collected 3 times, except for diet quality, also collected at 6 months too. All the outcomes that we're reporting are going to be differences from baseline to the data collection time point. And just a little bit more detail on maybe some of the less familiar outcomes. For our healthy purchasing outcomes, they were generated from the food purchased in the cafeterias using hospital IDs during the study period. So we were able to track each individual's purchases. And we used 2 specific purchasing outcomes. One is called the healthy purchasing score, which is basically a composite of how much green, yellow, and red label foods were purchased by the individual. As a reminder, green being the healthiest foods and red being the least healthy. Green is weighted highest, and red is actually weighted 0 in this healthy purchasing score. We also calculated average daily calories purchased from the hospital ID records. The diet quality was measured using the Healthy Eating Index 2015, which measures how closely an individual's diet matches that of the federal government's recommendations. It's calculated from 24-hour dietary recall data and ranges in theory from 0 up to 100, with a 5-point difference being considered clinically significant. So to look at the association between the Choose Well intervention and our outcomes by health literacy and numeracy, we use linear mixed effect models with an interaction term for the intervention and the cognitive still, meaning either health literacy or numeracy, in order to generate difference in difference estimates with our statistical significance set at an alpha 0.05. And we also adjusted for age, sex, race, ethnicity, and education. So moving on to the results, this is a table 1 of our sociodemographic characteristics, and this one is by health literacy. You can see lower health literacy in the left column and higher health literacy on the right column. Of the 602 participants from the main RCT, 510 completed the newest vital sign and general numeracy scale. Looking at the distributions of people within the lower and higher groups, we saw differences by race and ethnicity, with Black and Hispanic participants more represented in the lower health literacy group, as well as patterns of lower health literacy more represented by lower education level. And this also translated to the jobs that people had in the hospital. Those with lower health literacy also were more frequently in service and technician positions. And then this is the same sociodemographic table by numeracy. You can see that looking at the some of the patterns we saw with health literacy, we saw similar patterns in racial, ethnic, education, and occupation and numeracy data. So moving to the outcomes, these graphs show difference in difference estimates, with the error bars representing 95% confidence intervals. Blue is lower health literacy or numeracy, gray is higher. The analyses by health literacy are on the left side, and the numeracy ones are on the right side. So looking at these figures, we saw that healthy purchasing scores, which is the top half of figures, that they improved similarly in all subgroups of health literacy and numeracy at both 12 and 24 months. And while daily calories purchased decreased in both health literacy groups at 12 months, the reduction, once you looked at it by numeracy, was only significant in the high numeracy group. And this slide shows the differences of diet quality with health literacy, with the analyses by health literacy on top and numeracy on the bottom. At 6 and 12 months, we saw that diet quality was significantly higher, and it was significantly improved in the lower health literacy group, which was both statistically and clinically significant. And particularly at 12 months, the improvement in diet quality was higher in the lower health literacy group, was greater than that of the higher health literacy group, with a p interaction of 0.04. Looking at body mass index, we did not see any changes or differences in any of the subgroups of health literacy or numeracy for BMI at 12 or 24 months in the study. So just to summarize those graphs, we saw greater improvement in diet quality in the intervention participants who had lower health literacy at 12 months. We had similar improvement in healthy purchasing scores in the intervention participants in both those with lower and higher health literacy at 12 and 24 months. And then we did see that when it came to daily calories purchased, it was only improved in the higher numeracy group at 12 months and not the lower numeracy group. For our study, there are some limitations. The RCT is not randomized by health literacy or numeracy, and then our measures were our health literacy and numeracy measures were collected after the intervention. And then there is limited generalizability, considering our population was high educational attainment and not a lot of demographic diversity, though to be honest, this does represent, many workplaces in America. Just to wrap up, so this behavioral intervention that used automated personalized feedback and behavioral nudges led to healthier cafeteria purchases by all intervention participants, and then particularly improvements in diet quality among participants with lower health literacy, which those two findings combined together suggest that this group was also improving food choices outside of work. And so this is my contact information. I'm happy to answer any questions.
Thank you so much, Jenny. That was excellent. Please submit your questions for Jenny in the Q&A box or in the chat, whichever you prefer. I think my first question, I think you kind of were talking about a little bit, is do you think that this can really be applied in outside of a workplace setting? Any thoughts or ideas on that?
I think that it is possible. One of the nice things about cafeterias that we're looking at hospital cafeteria. There's cafeterias in many different types of environments, especially when I think about schools, and there are ways to track what people are purchasing, and if there's the way to sort of automate it where you've got a program that collects that data and turns out things like, for example, some of the nudges that we would have would include, if coupons if you bought so many green items in a certain amount of period, things like that, they're generated from essentially looking at the behavior of each employee and what they're purchasing from the cafeteria. I think that this is actually quite it's quite scalable.
Yeah. What kind of nudges do you think would be beneficial, say in like a school setting? Do you think you would kind of change those?
Yeah, it's certainly, we'd have to think about, one of the things that, I mentioned, but I just want to make sure it's clear, is that there was already traffic light labeling nudges in all the cafeterias that was sort of already at baseline before the study began. And so the study was really leveraging that labeling. I'd have to, when I think about schools, I'm not sure how much. So, I think as adults, we all sort of understand I'd say as adults, we understand, the red, yellow, green sort of to mean something. But to be honest, I guess I remember seeing them in school too as a
Yeah.
kid. So I think that even at a young age, there's already an intuition about those colors and what they mean.
Mm-hmm. Mm-hmm. And then what would you kind of say are your next steps? Is it, interventions to increase numeracy? What are you kind of thinking?
So I think with this, we're always, trying to, trying to figure out which, what are the, I think trying to figure out, what the components are, what are the most high yield nudges. Eh, yeah, I think, be able to sort of, when we think about scalability, figure out what are sort of, the real components that are effective in this particular intervention.
Mm-hmm. Mm-hmm. That makes sense. I don't see any questions for us in the chat. Please feel free to submit any that you have. Anything else that you wanted to share, Jenny, that you maybe felt like you didn't have enough time for, still kind of percolating?
I think I think that's probably the main highlights. I
Yeah.
was trying to stick to the timeline, so
No,
the
that's
time
okay.
limit. So I actually nothing off burning off the top of my head, but I think that it's that sort of as we think about how to improve health in this country, think about how we can alter dietary environments um, and interventions focus on that, that are a little bit more cognitively easy, sort of cognitively less demanding, a little bit more sort of intuitive, are very important.
Thank you. Thank you. Nice to see you, Jenny. Thank you for
Hello.
presenting and everyone for participating in the panel. And the next session starts on the half hour, so it's actually starts at 4:30 Eastern. So I'm hoping people can join us there. Please remember, if you haven't checked out the posters, that'd be great. And I hope to see you in the next room. And there's all kinds of next possible steps. Jenny, you're right. If we just did like, tax on sugar sweetened beverages, it would be like, there are bigger and smaller nudges out there. Some of them don't require us to be thinking so hard all the time. But if it's going to be kind of stuff that happens to at the individual decision-making level, then we need to empower people somehow or another. Hopefully that's what this field can help do. So I'll see you folks in on 4:30 Eastern in the next sessions.